be a fun talk. While he's getting the slides ready, I basically have just one simple request. We're doing procedures now for glaucoma, which is a condition of the eye where the pressure in the eye is too high for the nerve. It's slowly killing the nerve. People go blind from glaucoma. Normal pressures in the eye range from 10 to 20. We're able to do a surgery where we inject a stent into the eye drain that allows the water to leave the eye, which will lower the pressure in the eye and allow patients to get off drops. Currently, we have a device that'll inject, and historically we just injected one stent. The company produced an instrument that produces injection of 2 stents. It's right there in front of you. There's a larger version, so you can actually see the makings of it, and I'll come show that to you in a moment. And then the smaller version is actually what we use in surgery. But what I'll be requesting is that right now we inject 2 stents, but there was a misconception that you hit one button and both go in at the same time and it's done. And so they're only paying for 1 stent, although we're putting in 2. The reality is we're putting in 2 stents about 60 to 90 degrees apart. It's an entirely separate procedure. We'd like to get paid for that second stent. So one request instead of all those multiple ones that others were presenting. So that'll be the nuts and bolts of the talk. While he's doing that, I'm going to save time. I want to show you these instruments. The stent that we inject, it's the smallest stent known to mankind, but there's a speck of dust inside that.
That's a little.
That's a stent, and you'll see a picture of it, but here's a 10x magnifier from a jeweler. You'll have to, you can hold them both, but you'll have to use both with your trifocals to be able to actually even see it. It's the smallest implant known to man. It's there's 2 of them on the tip of this. But basically, when we inject it into the eye, we go into the eye this way. We retract that. We'll hit a button. It'll inject 1 stent. We'll come out, redo the whole process, go in and inject another one.
Okay.
And on coming out,
that was unclear.
Right. And
now you've clarified that. That's good.
And the trick is, you see how small that is in an eyeball that can move.
Yes.
That when we're coming out, once we inject it, if it comes over just to the side, that stent will get hung up on the injector and we yank it out. And then we have to go back in and put it in a second time.
Okay.
So that's a colossal issue that takes probably 15 minutes to correct. So it doubles the length of the procedure. And the whole time you're doing it, you're looking through a prism. You don't even get to look down straight in the eye. It's got to bounce at an angle. So
I have a question for you, if you don't
certainly,
mind.
Certainly.
If you go back to the technology where you put in a single stent,
Right.
how does that differ from this technology now, where you're apparently individually still putting in 2 stents?
It's the exact same technology, just 2 holes drain more fluid than 1. Did I answer the question?
But I'm saying the original technology was you used your instrument to put in 1 stent.
Correct.
But now you're saying, see, the concept that maybe my misconception was the injector put in 2 stents simultaneously.
No, it never has.
But what is the advantage if you're still putting in 2 stents individually?
You've got some slides to cover that. So why is 2 better than 1 as far as the patient's
No, it's
outcome?
it's not the question of 2 is better than 1. That's intuitive.
Yes.
It's what is the advantage of this over the other technology where you could just put into as individual stents if you wanted to then.
Gotcha.
Okay, I'll show you. There's a slide, I'll just jump right to it.
Arrow down.
I'm going to show you 2 things. Well, inside the eye, the water is produced by this structure. It creates the pressure in the eye. The water will run in front of the lens, through the pupil, and out through the side. And traditionally, the first technology, when we'd go in, the current stent is just a plug right through it. In the past, I don't have a picture of it, but I'll show you the effect. This.
Dim the lights a little bit so we can see your slides there.
Certainly try.
That's a little better.
These are the current stents in 2 different locations. The past stent was actually a right angle, and you would go in and actually start threading. You'd be tearing up the trabecular meshwork until it would finally stick. It's basically kind of like you've heard of the Cahook dual blade, which goes in and just rips out about 30 degrees of the drain. and it's unpredictable, which can create some significant problems. I just had a patient I had to send to Duke to fix that because the pressure dropped so low that the eye was collapsing. So we don't want to take those risks. But the old technology was you would just slide it across until it would hook, and you're just tearing up a lot of real estate. So what they did is to take that trough effect out, and they came up with a straight stent. And so now we can put one in here, and these are so much more titratable effects that we don't have to worry about the risk of the hypotony. If you don't have the eyeball's a lot like a
significant risk.
We've had 2 in the last 3 months that had the cahook in different locations. Me, I did one of them, and another one in Nashville that had to go to the specialist at Duke to get it fixed. If the eye doesn't have a pressure of 7, it doesn't work. Like a tire of a car, if it's too soft, it's not going to work. My patient's pressure dropped to 2, and so the eye is just slowly collapsing and not working. So
Closes off the drainage.
these don't take that risk. These won't drop the pressure that far, and so we don't have that downside risk. But to do this surgery, I've got a cut in the cornea, and we have to fill the eye full of jelly. And as I have that instrument in the eye, the jelly of the eye is coming out of the eye, and I'm slowly losing my view. It's just you got a little time window to get it in. And right about the time you get the first one in, you're losing your view. You've got to come out, you've got to refill the eye and go through all the mechanics and then rotate over 60 to 90 degrees to put a second one in. That takes time. It's just as much time as the first one does. And so the machine does not inject 2 at once. It's the same process twice. And so what we would like is the same amount of work that goes into the first one is going into the second one. We'd like to be paid for the second effort. 2, right now there's an incentive to just, if you can do the cahook dual blade, which most people are doing, and getting paid the same amount, why would they take the time to run the risk of doing these, which is a lot harder, takes a lot longer, and the risk of that thing, you see how tiny it is. If it doesn't stick, you got to fish it out of the eye, thread it back on that device, and try to do it again. Whereas if you're just going in there and tearing up the real estate real quick, it's simple, easy, and done. So right now there's an incentive to do the riskier procedure rather than the safer. And if y'all can approve this second payment, it'll incentivize the surgeons to do what's better for the patients. That's it in a whole nutshell. And I've personally experienced it 2 months ago. I sat with this patient for 3 months trying to fix her pressure. I couldn't fix it. And I do more of these than anybody in town. In fact, all 4 of my guys in my group were the busiest eye surgeons in town.
Well, that's very helpful information. I do appreciate that. It makes the picture a lot different in the considerations.
Questions?